Okay, we are returning again with our 6th annual Functional Medicine Symposium with our guest lecturers and speakers. Today, I'm honored to have Dr. Mobeen Syed, Dr. Bean, as everyone knows him. He's going to give a presentation updating us on some of the interventions with the FLCCC protocol. Dr. Bean, take it away. Introduce yourself to our audience, please.
Thank you very much for having me. So this is Dr. Mobeen Syed, known as Dr. Bean. I have been talking about medicine. I'm a medical teacher, and I run drbeen.com. I've been teaching for 25 years now. I am a software engineer as well. So with that introduction, of course, the majority of the talks nowadays that I've been doing for the last 2.5 years is long COVID vaccine injury. And I think it would be interesting today to go over the vaccine injury and long COVID management protocol by FLCCC and talk about some drugs and some interventions and why these interventions are important from a mechanism point of view. Having said that, a quick heads up, I have slight cough for some weeks now. So my apologies in advance. I will try to be as careful as I can, but that is just one quick heads up. So let's start our discussion. I'm going to share my screen and show you the FLCCC protocol. So if I go to the top of this one, this is I recover post-vaccine treatment. I think it's a very similar protocol for the long COVID as well. Actually, if you go to the I recover long COVID, that then ties here. In this protocol, it is interesting to look at the pathophysiology. However, I want to go over some of the medications or interventions here in the first line therapy. I will talk a little bit about the near infrared as well, which is, I believe, not here. Actually here, sunlight and photobiomodulation with methylene blue. So let's start our discussion. The symptom clusters, if you look at the protocol here, there are many clusters, for example, neurological, autonomic, GIT, respiratory, musculoskeletal, even endocrine, POTS, postural orthostatic tachycardia syndrome. The 3 big ones that I have been observing, seeing in patients, and then have been teaching about them are the neurological symptom sets, musculoskeletal symptom sets, and the cardiovascular symptom sets. And I think why these are big ones are, number one, their prevalence is more, and number two, these symptom sets cause real anxiety and depression. Neurological symptoms can cause depression just because of the congestion and the inflammation within the brain tissue, which one of the outcome of that can be the depression and anxiety and mood changes. But in addition to that, a patient's perception of their life changing, probably forever, it's very depressing. Similar situation for musculoskeletal patients. When a patient cannot wake up or after waking up cannot get up from their bed, cannot jump out of the bed and start doing their daily routine, has to, if they're holding their mobile phone and their arm becomes tired, they're cooking and their arm becomes tired, they're walking upstairs and they cannot. That for youngsters, it's for everyone, but for youngsters especially, is very, very depressing. Most of the time when patients talk with me, they tell me that I am giving up, I'm disappointed, I am hopeless if this is my life is. And the third one, cardiovascular, that has a lot of scare in it. Patients feel that I would get a heart attack anytime. I'll get a cardiovascular event anytime. I have family, I have children, I have just started my life, and what has happened? Of course, other symptom sets have their own emotional outcomes as well, but these are the three that I have seen bothering and depressing people a lot. So I want to make sure that as we look at these, we connect them to these, look at these interventions over here, we connect them to these main symptom sets. So I'm going to start with the intermittent daily fasting or periodic daily fasting. Excuse me. The periodic fasting usually becomes where one is fasting for a day and then not fasting for a day and so on. And intermittent daily fasting is usually, these are, I think, interchangeable terms, but intermittent is usually some hours of fast and then some hours of eating. And I want to make sure that we understand why this is important. And I'm going to draw a little bit, which is my general way of working. So let's use one of the studies that has said that in the brain tissue, for example, at the border of the blood vessel, so let's say this is blood vessel, and the brain tissue, let's say here is the brain tissue, at the border or the boundary, monocytes may be sitting here with spike proteins piece S1 stuck in the monocytes, which in turn causes these monocytes to be upset. And that is a function of the immune system cells, that when they phagocytose something or when they have something to process, their processing units, they will release the inflammatory mediators. And the function of these mediators is to cause inflammation. So in their own little behavior, they are trying to fight off a problem and protect the tissue around them. But in fact, they are really causing damage to the tissue around them. Plus, there is inflammation and resultant congestion of the brain. So when the congestion of the brain occurs, that causes psychological effects, that causes cognitive effects, that causes memory and speech, and a lot of such effects are also possible just because of the inflammation and congestion. And one way to observe that is that in some patients of long COVID or vaccine injury who have neurological symptoms, they actually would be going through hills and valleys. So sometimes they're feeling better and sometimes they're not. And when they're feeling better, you would see that very rarely you would see a permanent damage. In fact, you would see them recovering, and during their recovery, they are operating very well, which means that the tissue damage has not occurred, fortunately. Of course, if this state stays for a long time, then the tissue damage would occur as well if congestion and inflammation stays there. Now, intermittent fasting is a very interesting phenomena in this kind of a state. So let me first offer you a thought. Imagine if we put the intermittent fasting on a side and we ask all of our mechanisms of our body to operate and try to get this little trash or waste product, part of spike protein S1 sitting in the monocyte, try to get that out. And you would see that the only possible mechanisms are if the cell itself can process whatever is in there and digest it, break it down, and either use it to make other things or to make energy or to throw it out. That's one possibility. The other possibility is similar, but in the other possibility, the cell would break down some parts of this offending agent, and then it will present that on its surface, which would allow the other immune system cells to come in and bind there and become activated and kill this cell, the cytotoxic behavior. But there is no possibility of sticking your hand in, a virtual hand, in the cell and extracting the offending agents. So then, of course, you'll say that, fine, let's go with these two mechanisms. These two mechanisms should be sufficient to take care of this situation. The problem is that the spike protein species are capable of turning off the presentation pieces of the monocytes, or turning off the monocytes' normal behavior towards digesting and presenting. So monocyte ends up continuing to produce the mediators, but the offending agent stays stuck. So now we are not getting digestion, and we're also not getting the immune system killing the cell, because the protein is not presented outside, because the protein is not broken down. So now what do we do? This is the situation where a patient is going to stay in inflammatory state, especially in the boundaries of the vascular system. That can be brain, that can be skin, that can be cardiovascular system. So this solution, one of the solutions, is intermittent fasting. What happens is that during the intermittent fasting, so let's say we now make that cell back here. Let's say this cell has some trash sitting. These are pieces of S1 protein here. And the cell is sitting there. Cell is all upset and it is releasing mediators. If you let this cell pass through or go through intermittent fast, let's say out of 24 hours, let's make it 6 hours and 18 hours, or 8 hours and 16 hours. There's a window of time when you can eat and one window of time where you cannot. So let's say here 18 or 16. Now what happens is, during the, let's say, 8 hours window, something that is called macro-autophagy starts. And now, of course, the autophagy simply means eating self. What that means is that, as imagine us, when we are hungry and we are not given food, our body starts looking for the nutritional substances present within us. Glycogen, stored glucoses in various parts of our body, circulating glucose, then fats, and then even after depleting the fat stores, if at all, if the person just stays starving, lost somewhere in a desert, then even proteins, muscles. Similarly, our cells, when they are starved, when they are hungry, they would look inward to say, do I have something inside of me that I can recycle and use? And when they do that, that is called autophagy. So when a patient of inflammatory state, not necessarily just long COVID or vaccine injury, any long or chronic inflammatory state patient, when they do intermittent fasting, their cells will start looking at the things present inside of them. So you probably have a question here, and that would be, well, if the cell was not able to break down these things before, why would the cell be able to break it down now? And the answer is that a regularly fed cell breaks down their proteins through a process called ubiquitination, a different mechanism of breaking down proteins. And in this case, that mechanism has failed. But when you make this cell hungry, then a new mechanism, actually a couple of new mechanisms, they appear. One of them is called macro-autophagy, where just near the trash, near the offending agent, a small vacuole starts forming, a small organelle starts forming, which would just take a part of this trash and then recycle it. This is called a phagophore formation, and this is a autophagosome formation, which then leads to breakdown of the content. In the 16 hours window, so let's say this is where you have eaten the food here, and then there is 16 hours of a fast and you are sleeping during this time as well, and then you'll eat here. During the 16 hour, there is another special kind of autophagy mechanism that becomes activated, and that mechanism is called chaperone-mediated autophagy. What that means is, again, this trash is of interest to us. So what happens is there are proteins called heat shock proteins, and then heat shock protein 70 is what is interesting. That protein picks up pieces of these trash lying around in the cell and brings them to recycling units, proteasomes, and gets them to be destroyed. But these mechanisms only become active when the cell is undergoing a stressful situation, for example, a hunger state. Now, not only we are digesting the components, we are also doing something very interesting, and that is that as we break down, as the cell breaks down these components, cell is going to present some of those broken down components on its surface, which would allow the local immune system cells to kill this cell if necessary. So now if this is an old immune system cell, like let's say monocyte, which should not become old because monocytes have a shorter lifespan, but if you put something in them that is offending to them, then they would just keep living on for a longer time till they can get rid of this. So if this is an old monocyte, which is just continuously producing mediators, and if we can kill it, that would actually resolve congestion. This is, in short, the mechanism of intermittent fasting. So you can imagine how well the patient would respond. May this be neurological issues or cardiovascular issues or musculoskeletal issues. If these issues are related to the waste products present in the cell and immune system misbehaving or malfunctioning, then intermittent fasting really helps. Now I want to connect with this the methylene blue and sunlight and photobiomodulation, because the second component, the second component to manage is the mitochondrial damage, and melatonin comes into that category as well. So what happens is, inside a cell, we have nuclei and many organelle. I'm just going to make nuclei because that's near where I can make mitochondria. So here is a bunch of mitochondria near nucleus. Mitochondria are usually present near nuclei because nucleus is sending the orders outside to make proteins, and mitochondria offer energy. So you can say that near the factories are the powerhouses to provide energy to the factories. So mitochondria, if they start malfunctioning, what will happen is that inside the mitochondria, as they're making energy, in case of the inflammatory states, long COVID, vaccine injury, mitochondria starts functioning incorrectly and not making ATP. ATP is the energy units. So mitochondria end up not being able to make ATP correctly. And the reason for that is, we've done this discussion before as well. There is a thing called electron transport chain. So in the mitochondrial membrane, there are machines, enzymes that are sitting together, 4 of them, and then a little ATP synthase. So these are the machines that are sitting there. So these are called complexes, enzyme complexes, complex 1, 2, 3, 4. Their function is basically to work with electrons. They move electrons through this complex, and finally they give this electron to oxygen, and then they make water in that process, or carbon dioxide. They take actually water and they make carbon dioxide, plus they remove hydrogen. The end result of this is that there is electrons that are being moved through this system, and finally hydrogen is brought into one direction, and then that moves through this ATP synthase, and movement of that helps this enzyme produce ATP. Of course, this mechanism, which I just very roughly and in a high level way explained it, because what I want to explain is that if this mechanism does not work correctly, then we end up with two problems. One problem is that this mechanism, when malfunctioning, will produce reactive oxygen species, or it will make runaway electrons, which would then go out. Imagine that these are in here. This is what's happening here. These runaway electrons or the reactive oxygen species would actually come out. They would then, imagine these are like welding machines. So wherever they will go, whichever membrane and lipid or protein they would go near, they'll start welding them. They'll start adding that energy into those targets and deforming them and causing them to malfunction. And then depending upon what is deformed, for example, if it is cell membrane that has become deformed now, and it is now malfunctioning, one malfunction may be that the cell membrane develops a hole in it. And now things can come in and things can get out, and all of a sudden the cell has become unstable. So that is one problem. The second problem is that because this machinery is not working correctly, the ATP production goes down. So when the ATP production goes down, the cell thinks I'm under stress because I cannot make energy. And these stress-related reactions start. And part of that is the cell would either die or cell would start creating mediators and markers that would tell the nearby immune system cells that there is inflammation needed because there is some problem going on. Now, this mitochondrial dysfunction happens almost in so many tissues, not just the brain tissue, but also the musculoskeletal tissues, also the endothelial and heart tissues. The result is, depending upon what tissue has mitochondrial abnormality, that tissue's function will be abnormal. And how do we improve this? It is such a wonderful thing in this protocol. The way to improve this, one of that is methylene blue. And please make sure that you look at the contraindications for methylene blue, that when do you not take it or when do you take it with care. There are absolute contraindications. For example, if you're taking SSRI, you cannot take methylene blue. You should not take methylene blue. Similarly in pregnancy. So please make sure that you go online and look at contraindications and side effects of methylene blue before, plus the drug interactions. I cannot cover them all. That would become a lecture in itself. So considering that you have taken care of all of those things, methylene blue is a substance. What that does is it helps donate electrons to this chain when the previous steps are not working correctly. So it can bring electrons to the step 4. Now, step 4 was supposed to get electrons to the other steps, and the other steps were not working correctly, and they were even leaking the electrons. Here comes methylene blue and starts donating the electrons. Methylene blue can actually start accepting the electrons as well. So it can catch the runaway electrons and it can donate the electrons to the 4th complex. And the result of that, it can even act as a chromophore, as a color. It is blue in color, right? So it can act as a chromophore to absorb photons as well. So a lot of beautiful mechanisms are done. The end result of that is it would kickstart the electron transport chain. And the result of that is that mitochondria would start functioning correctly. And as soon as mitochondria functions correctly, one, there will be less reactive oxygen species released, so less damage to the cell. Number 2, there will be more ATP production, which tells the cell that, hey, I am normal, and start doing the normal actions. Number 3, there will be less cytochrome C-like things. Cytochrome C is also a part of this electron transport chain, and when the transport chain is not working correctly, it releases cytochrome C as a message to the world around to say, hey, we are in trouble. So that electron, the cytochrome C, can come out and cause inflammatory cells to attack these cells and cause inflammation locally. All of that would be stopped. So mitochondrial health. And if you see a lot of patients of long COVID and vaccine injury, when they do mitochondrial tests, they find out that their mitochondrial health is not correct. And methylene blue is something that very tiny dose, it's not even, I think 5 milligram per day, once a day, then twice a day. That's about it. That can actually help a lot by restoring mitochondrial function. And then I also want to talk about sunlight and photobiomodulation. Excuse me. This is another very, very important topic, again, related to the mitochondrial situation. So what happens is that in the morning, so let's say, so let's say here we have a person. If you've been watching my lectures, you know my persons are like this. So here is a person. And then the sun is going to rise in the morning and go through this and then set in the evening. In the morning time and evening time, the sun rays that fall, and I got to say that Dr. Paul Merrick has done so much work in these areas. I've been working with him on these things, and so I must mention him. So as the morning sun or the evening sun shines on you, this sun has more near infrared and less thermal heat. And you can probably vouch for it, that morning sun is more soft in terms of how harsh the light or the temperature it creates. Similar for the evening sun, but the remaining day's sun can be burning hot. The morning and evening sun has more near infrared and less sauna or less thermal heat. The remaining day's sun has more thermal heat. It produces more energy, heat energy, and less near infrared. So this near infrared taken in the morning and evening is very important, and I'll explain why. But imagine this, that you sit down in a balcony or outside, or you take a walk in the morning if you have vaccine injury or long COVID, and expose yourself to near infrared if you do not have a lamp. If you have a lamp, then you can expose yourself to near infrared lamps as well. Now, the optimal duration is 10 to 15 minutes. And there are studies that say don't go beyond 15 minutes. Although I know a patient who said that I stayed within 15 minutes, I did not get any benefit. And then I increased it beyond 15 minutes and I felt a benefit. However, studies show that these are in vitro studies. They show that the benefit of near infrared is within 15 minutes time. After 15 minutes, it activates the proteins in the cells that actually become harmful for the cell instead of beneficial. So I think you'll have to figure it out for yourself to see, starting from 10 minutes, to see, is it 10 minutes, 11, 12, 13, 15, 16, 17? What is the duration that helps you the most? Second thing is that when you're taking near infrared, let's say you want to be exposed to near infrared only for 15 minutes and you have a lamp. So you face the lamp, and then after 15 minutes, you turn yourself and you face the other side. Near infrared can penetrate up to 4 inches, number one. And number two, it can go through the bones and clothes. So it's not necessary for you to not have clothes on. For example, for the thermal heat, it can go through the clothes and it can go through the skull bone as well. This is why it is important that, and my apologies, I had given you a heads up about my cough. So this is why it is important that even if you have a near infrared lamp, train it towards your head so that it can pass through the skull and the brain can actually take advantage of it. Now, what does near infrared do? And that's a very interesting concept. I'm going to go back to this one. And for this concept, I'm going to remind you of thinking about a plant. So plants or the trees, they have this green color in them, chlorophyll, right? And it's a chromophore. Chromophores are the colors, which of course all colors do this, which absorb some light and then do not absorb other, correct? Do you know that within our mitochondria, complex 4 is a chromophore? It's a color complex. That means it can absorb light. Just like chlorophyll in the leaves can absorb light and then convert that light into helpful energy production, which then plants use to grow. The component 4 does it. So when you give near infrared, complex 4 acts as a chromophore and captures the photons coming in and uses that to run. So even if the whole mitochondrial chain isn't working correctly and you shine the near infrared on it, the complex 4 starts working, which would then allow the ATP synthase to start working as well, and the mitochondria would start functioning again. And as soon, this is like jump starting a car. And as soon as mitochondria would start functioning again, then the overall state of the cell would change, as I had mentioned before. In that process, the whole mitochondria would start becoming healthier as well, and the whole thing would start working. It's like unclogging a clogged system. So in this protocol, intermittent fasting, methylene blue, and photobiomodulation are very important pieces together, which should be looked at. So again, I cannot advise you to do this, but with your doctor's advice, with your protocol, with your other educational activities, figure out what is the best for you in this protocol. Now, very quickly, just 5-6 more minutes. Very quickly, other pieces that are here. Ivermectin. Ivermectin, you might think that, hey, ivermectin may be just useful for spike protein. But ivermectin is an anti-inflammatory as well. So it actually is a potent anti-inflammatory. That is why it is used by rheumatologists for various conditions and by dermatologists for the skin conditions as well. Not only that, ivermectin can actually be a blocker of the spike protein. But let's say that the patient does not have spike protein. I sometimes feel that we are hung up too much on the idea that spike protein is everywhere. There is a theory by a Dr. Neil Jenkin, and I'm writing it down so you can Google it. Neil Jenkin, in somewhere in 1959, I believe, he gave a theory called network theory. And so you can actually Google network theory by Dr. Neil Jenkin. And this theory was the following. If I can explain this theory, I would be like Uber teacher because it's a difficult theory. But let's see. Imagine you have spike protein, or someone has spike protein. And let's say these are the S1, S2 pieces. What we do is our body will create the antibodies against the spike protein, correct? This is a normal, natural behavior. So this is the antibody. Now, antibodies have a binding site from where they bind to a part of the protein. One antibody cannot bind to the whole protein. It's not like a hand that can engulf the whole protein. It can only bind to 7 to 12 amino acid, very tiny bricks of the proteins. Interestingly, in a spike protein, there is a thing called receptor binding domain, RBD. And then within the receptor binding domain, there is another tiny part that is called receptor binding motif, or RBM. The receptor binding motif is the one that actually binds with ACE2 enzyme and activates it. Receptor binding motif is a very tiny piece of protein. I think it is 10 or 12 amino acids long. So the actual payload that works with our ACE2 in a spike protein, which spike protein is thousands of amino acids, but the actual part that actually does the damage, that is only 10, 12 amino acids. So that means we can actually produce an antibody that binds with just that part. Now, this much is good. If this happens, we will be able to clear the spike protein with this antibody. Jenkin said that our body, as a part of homeostatic mechanism, that means a normal physiological response of immune activation, is our body creates one more antibody. I'm going to make that in red over here. This antibody will actually be made not to bind with the spike protein. Of course, we'll make many kind of antibodies to bind with the spike protein. But this antibody will be made to block this antibody. This antibody can bind with this one. So let's look at their names for a second. This antibody is called antibody, correct? What should we call this one? This one, of course, should be called antibody. However, Jenkin named it something different. Why? Because he thought that because it is binding to this part of the previous antibody, this part is called the idiotype of the antibody or variable region of the antibody. Variable region means that these antibodies are actually all the same as long as this part of them is concerned, but their binding parts are all different. So they are variable. That's why they're called variable regions or idiotypical regions. Idiotypical meaning unknown regions. They're all different. And because we are seeing that this antibody binds with this region of the other antibody, we call it anti-idiotypical antibody. That this antibody binds to this idiotype of the other antibody. So I have a couple of things for you to think about. Tell me this. This binding region here binds with this part. Now this binding region also binds with this part. So could I say that this part of the spike protein, let's call it A, the receptor binding motif, and this binding region of anti-idiotypical antibody, they should be the same because that is why they'll bind here. Correct? Now, excuse me. According to Jenkins, these antibodies were produced to clear these antibodies out, and this is a physiological mechanism. Any free antibodies will become a complex with the anti-idiotypical antibodies, so these antibodies will not have biological functions and they'll be cleared out, and that is why they would not create inflammation. That was a theory. This theory is proved. So there is a Dr. Bill Murphy from UC Pleasanton who has been, he heads up a immunology and oncology lab, BSL-3 lab. His team did this research and they found out that anti-idiotypical antibodies are present in acute COVID and long COVID. Now, why is this antibody bad? It is good that it would help clear out the other antibodies, but if it persists, what is bad is this part of the anti-idiotypical antibody is very similar to the receptor binding motif. That means it can bind with ACE2, and that means it can activate the ACE2 just like the spike protein activates ACE2. So many times when we are sitting and contemplating as doctors that here is a pathology that should be triggered by the spike protein, so must be there is spike protein lying around. It may not be the spike protein. It may be the anti-idiotypical antibody, and this may be an autoimmune disorder. And I'll actually offer you a proof for my thinking here. And this is actually a study as well. The proof is this. If we say that there are spike proteins going on for months after months, then there must be a source of spike protein somewhere. And so if there is a source of spike protein, let's say for the messenger RNA type vaccines, there is an incorrect thought that mRNA would just keep making spike proteins for months. Yes, it would make for some times. There has been studies that even up to 5-6 months. But 1 year, year and a half, where would those spike protein come from? But if we have an autoimmune disorder now, and if we are producing the autoantibodies that behave like a spike protein with the ACE2, then yeah, these can be produced forever unless you control them. So keeping this in the back of your mind, that we have anti-idiotypical antibodies that may be activating the ACE2 enzyme, which is causing inflammation throughout the body and which is causing cardiovascular issues. Guess what we can do? We can try to remove the anti-idiotypical antibodies. And guess what drug that binds with the receptor binding motif can bind here as well? Ivermectin. So this is why ivermectin, in some cases, it depends who has this. In some cases, ivermectin is useful because it is not just binding to spike protein. It is actually binding to anti-idiotypical antibodies as well, which behave very similar to spike protein. So I think that this might be an interesting thing to note. So that means somebody who has long COVID or vaccine injury should try ivermectin. If it helps, there are going to be two possibilities. Either there is early disease and the spike proteins are present, or the disease may be later, but anti-idiotypical antibodies are present. This in addition to the anti-inflammatory behavior. But if ivermectin did not help that much, that would mean that it is doing its anti-inflammatory behavior, but either there is no spike protein or there is no anti-idiotypical antibodies, so it is not interfering with those. So the pathology may be something else. Then one more thing and we stop. That is the low-dose naltrexone. And what I have done is, before this lecture, I went over to my own channel, this Drbeen Medical Lectures. I have discussed low-dose naltrexone over there. It is an IL-6 modulator. I would explain that a little bit here as well. In addition to that, role of magnesium is here as well. In addition to this, this is long story short. This is FLCCC's channel on YouTube, long story short with FLCCC. Over here, these are actually my videos. And if you see, this is nattokinase. I discuss a little bit about lumbrokinase in here as well, nattokinase over here, and then same long story short, autophagy with intermittent fasting, spermidine and resveratrol. I've discussed them as well. Actually, between these two channels, everything that is present here is covered. So with that little help, the low-dose naltrexone has a very interesting mechanism. Let me actually use this video of mine. Low-dose naltrexone modulates the immune system by modulating interleukin-6. In that process, it improves the regulatory system of the immune cells. It helps improve the osteoblast activity compared to osteoclast. So bone, there are some people who develop bone pains. It actually helps reduce that bone pain by improving the bone cells' balance of their function. In the cardiovascular issues, you would hear this from some of the prominent cardiovascular pathology theorists for the long COVID and vaccine injury. You'll hear VEGF again and again, vascular endothelial growth factor. Vascular endothelial growth factor is usually released from the blood vessels and inflammatory cells to help produce more blood vessels in the injured area. So, excuse me. So I have made that over here. So this is a blood vessel, and there it is making a lot of branches. VEGF's function is to create sprouts of blood vessels to make new blood vessels. Those new blood vessels are not always a good thing. We do not want every tissue to have extra blood vessels in them. Plus, when these blood vessels are being formed, they produce edema because these are leaky baby blood vessels. So this would cause skin issues, inflammation under the skin, edema under the skin. It can cause blood vascular issues in the brain, in the joints, and so on. Low dose naltrexone helps reduce the VEGF production. So that also reduces edema and inflammation and joint pains and the muscle pains. Then low dose naltrexone also increases the dermal fibroblasts. So fibroblasts are the fibers present in almost all of our tissues, and they make fibers, they make collagens and others. Low dose naltrexone modulates them as well, so that there is no extra scarring. So it doesn't just increase the fibroblasts, it balances them out. So the amount of collagen and fibrin that is needed is produced, and not more and not less. And of course, in the beginning, here, interleukin-6, and there is effect of the interleukin-6 on thrombocytosis, on the liver's production, on the immune cells function. The point is, low-dose naltrexone should be tried whenever there is vaccine injury or long COVID, because my observation so far is this is the mainstay drug for these conditions. There are many other exotic drugs. Melatonin is very important here. Aspirin is very important. They're all important, and there are some more exotic drugs as well. But these therapies, intermittent fasting, methylene blue, sunlight and photobiomodulation, near-infrared lights, low-dose naltrexone, they are kind of the backbone. I have not, Dr. Saleeby, I have not delved into the probiotics and peribiotics. That in itself is a huge topic, but thank you very much.
Yeah. Thank you, Mobeen. It was a fantastic deep dive into some of the therapies that the FLCCC has put up on their website. Probably a little too much for the average Joe on the street, but certainly the clinicians who are attendees at this lecture will find it very intriguing and very interesting and want to learn more. And of course, you offer a platform for educating in the dive deep into the basic science of all this. And I must agree in your opening comments about neurological and musculoskeletal changes causing a widespread depression, as well as the cardiovascular symptoms causing anxiety. I see that in my clinical practice all the time. Yeah. And I'm glad to know there's more to just autophagy 101. There's now a macro-autophagy and the subcomponents of that. And I'm sure as we go further into discovery on this disease process and how the body works to minimize it or mitigate it, we're going to find all kinds of more information. It's not going to be as superficial as we once thought. Can you comment a little bit about mitophagy as well? Is it the same mechanisms of action briefly?
So mitochondrial autophagy or mitophagy has similar effect as well. The only one additional mechanism that I would like to add is macro-autophagy that can help with the mitophagy. So macro-autophagy is, let's say there is a pile of trash over here and you make a little trash bag near that and you pick that up and recycle it. Chaperone mediated is that there is a pile of trash here and you make a heat shock protein over here and that comes in and picks it up. Micro-autophagy is where you'll actually, you're a practitioner and you're a doctor, you'll be amazed with this one. The lysosomes are brought near the vesicles or organelle that are not functioning correctly. And they're attached, they're fused with them. And those little lysosomes, like a little Pac-Man, take a bite out of it. We did not know that this can happen. We always thought that phagosome and lysosome, they bind together. But in micro-autophagy, these things can go and they can help mitochondria. Mitochondria can recycle itself as well with its own little enzymatic behaviors. But we can also do micro-autophagy with the mitochondria to do mitophagy.
Is that why on electron microscopy we see the cristae in a disorganized pattern when there's dysfunctional in the mitochondria, and as it corrects,
Correct. So
that pattern comes back?
Yeah, so there are multiple reasons for that. One of the reasons for that is that as the electron transport chain starts becoming disrupted and the reactive oxygen species start causing damage, that damage causes the abnormality in the shape of the mitochondria. The micro-autophagy will be observable when a piece of mitochondria has been broken off, has been bitten off. That is the indication of micro-autophagy.
Gotcha. Now, one practical question for clinicians practicing is in the use of methylene blue. If you're dosing at BID, how long after ingestion should one wait to go out and do the photobiomodulation?
So that's a good question. The photobiomodulation within half hour to 1 hour, methylene blue is actually rapidly absorbed and distributed. So within half hour to 1 hour, photobiomodulation can be started.
Okay, good. And I guess if we're dosing at BID morning, evening, 12 hours apart, it would make sense to get out in the morning during that window of opportunity for near infrared. Same thing in dusk.
Correct.
So
if somebody doesn't, absolutely correct. If somebody doesn't have the lamps, it is awesome to actually, if you go out, that has a better outcome, because if you go out and you are in a park, then there are phantom sites by the plants as well, which also reduce your stress levels, which also reduces your norepinephrine, reduce cortisol levels, which themselves are very healthy.
Right. And getting out this part, meditating, walk, brisk walk, and get some exercise in, and also make a little vitamin D.
Correct.
So one thing I came across, it was a webinar not long ago, a few days ago. They talked about the mito swab. Apparently it's a buccal mucosal swab that checks mitochondrial health. Are you familiar, and can you comment on that?
Correct. So one of the vaccine injured patient has been sharing her labs, excuse me, and she very recently got her mito swab done. Mito swab is I think, up and coming organization or a company. They are doing this, and it's a new technology as well. And they are further improving that too. But it is a very interesting lab, especially to see how mitochondria are. One thing that I had requested her was to do a control. And so another vaccine injured patient who also has a large organization trying to help others, he was saying that they are setting up mito swabs with healthy and injured patients to see the difference.
Right.
So I like this. It just is in the beginning.
In the beginning, yeah, we need more science, more data on it. Very good.
Right.
Well, listen, I know, thank you so much for this discussion, and I have a follow-up interview with Paul Merrick, and he's going to be talking more about photobiomodulation. So that'll be a great follow-up lecture to yours now. And I must, again, thank you so much for all your knowledge and continued work in the educational arena for us doctors.
My pleasure. Thank you very much for having me.